Very good morning, ladies and gentlemen. It's my pleasure to present to you today. My name is Dr. Paul Richardson, and I serve as the Director of Clinical Research at the Jerome Lipper Myeloma Center at Dana-Farber Cancer Institute in Boston. And what I'm talking about with you today is the emerging role of CELMoDs as a next generation therapy in the management of myeloma, and to provide you really with a clinical perspective, but also to discuss with you some of the basic science that underlies it. Now, the complexity of myeloma biology is well understood, I think, to many in the audience, but I think it's just critical to understand that immune dysregulation is a fundamental part of the disease process. And whilst multiple myeloma is an incredibly complex and heterogeneous disease, multiple myeloma is the operative term, I think an underpinning of the pathobiology lies in immune dysregulation, an aberrant stromal structure, the disruption of the cytokine milieu, and this clonal evolution of cells that occurs in a very diverse and complex fashion. And I think what's also equally important to understand is this interaction with the microenvironment that extends beyond the bone marrow per se and into the actual cortical bone and other sites of disease, such as, for example, the extramedullary compartment. Now, with that in mind, in myeloma cells, it's important to recognize also the dependence upon the Ikaros and ALOS pathways and the emerging scientific data to understand that the Cereblon E3 ligase complex is a prime target in this disease process. So with that in mind, CELMoD agents have been a uniquely designed group of molecules, and they belong to a class of E ligase or E3 ligase modulators. And so they have a shared target with immunomodulators. But what's really important to understand is that the CELMoDs are distinct. And so the shared target with the IMiDs is real, i.e. the Cereblon E3 ligase complex, but their downstream effects are quite different, and the molecular structures are different, and their engagement in the Cereblon E3 ligase pocket is substantially different, and that's what sets these agents apart.
Could you just clarify a little bit more about what the difference is between a CELMoD and an IMiD? I always thought they were kind of the same and that CELMoDs were just a little more effective, but it sounds like maybe qualitatively they're different.
They are, Neil. They're essentially, obviously, they're orally bioavailable, which is a huge plus. But the important point is that they were intentionally designed to more efficiently degrade targeted proteins. So the way I think of them is as really degraders, and they are essentially molecules that engage the Cereblon E3 ligase complex differently and broadly with greater potency. And so in a way, it's a little bit like the proteasome inhibitors. You know, they're one broad class, but within them, there are very distinct molecules. And CELMoDs are quite distinct, in my opinion, from immunomodulators in that regard. And I think the preclinical models help us understand this because you can see in them that there is a much more efficient substrate degradation. And this results in not only tumoricidal effects, but really differences in immune activity. So if I can use iberdomide as an example, Neil, essentially, this has its direct anti-myeloma and immune stimulatory activity in preclinical models. But what's particularly interesting is that it's able to overcome lenalidomide and pomalidomide resistance in cell lines derived specifically for those features. And it enhances cell-mediated killing through immune stimulation. And so this is actually a graphic that I think really helps. As you can see to the right, the engagement of the pocket illustrated by lenalidomide in the first picture. And then when you look at the, if you look across the slide further to the right, so to the left is lenalidomide, and then to the right is iberdomide, CC220 as it's called, you can see that this engagement in the pocket is substantially greater. And so this results in a series of characteristics, which are summarized on the left of the slide here, where we show that essentially there's a 20-fold more efficient degradation factor for, in fact, iberdomide alone. And so interesting as well is that there is this synergy with other backbone agents preclinically, both bortezomib and daratumumab in preclinical models. And as you can see in the graphic again on the right of the slide, the substrate degradation factor is dramatically different. So this is essentially a summary of just the point that's made. It's a potent drug differentiated from the IMiD class, distinct chemical structure, and as a result of this has preclinical features that have in turn translated into the clinical space. Now, a couple of other preclinical stories to share with you. This is, I think, a very important graphic that builds on what we've just discussed, but at the same time shows to the right here the impact on IL-2 secretion by peripheral blood mononuclear cells, and then you can see the impact on myeloma cell survival in co-culture, where clearly iberdomide stands out from the len and pom controls in these experiments. Now, how is this translated into clinical trials? Well, in this context, there are a number. These are actually iberdomide studies in relapsed refractory myeloma. The Excalibur trial is ongoing, led by my colleague Dr. Sagar Lonial, and this is an international trial comparing iberdomide combined with daratumumab and dexamethasone to Dara-VD as the control. And then there are a number of other studies that are exploring the role of iberdomide in early relapse with combinatorial strategies included. And I think what's important to note is that it's now moving into the upfront space as a potential replacement for lenalidomide in the future. And this, I think, is extremely interesting and exciting. And I think it's particularly important to share with the audience that not only is iberdomide that much more potent, but there may be some safety features which set it apart. One of the most interesting, which applies to the CELMoDs, not just iberdomide, but also to mezigdomide, which we'll be talking about in a moment, is that this second cancer concern that's generated by lenalidomide and specific mechanisms relating to p53 do not exist for these molecules. And so we're very hopeful that that'll translate clinically into a lower rate of second cancers. Now, what do we have in terms of data? Well, this is actually Sagar's work published in Lancet Hematology last year, and a privilege to be part of this trial with Sagar, where we looked at iberdomide combined with dexamethasone in heavily pretreated patients. And essentially this was the so-called MM001 study. And this is a quick summary of the study design, but just for the audience, the essence of it was the combination of iberdomide and dexamethasone in patients with relapsed refractory disease. Cohort B had to have had at least 2 prior therapies. Cohort D had to have had at least 3 prior therapies and were classically triple-class refractory. And we looked at endpoints including overall response rate and secondary endpoints including progression-free and overall and progression-free survival, overall survival, and duration of response. Now, I think the first important thing to share is the sort of disposition of the 2 cohorts in this study. This is a substantial experience. In cohort B, which was the dose-finding aspect of the trial, 90 patients enrolled, and then in cohort D, 107. And what you can see here is the distribution of patients. Median age was 65, very typical of a phase 2 population in relapsed refractory disease, but our oldest patients were 71 and 73 respectively. And so in the dose escalation cohort, again, heavily pretreated, extramedullary myeloma in about 20%, and high-risk cytogenetics in the dose escalation group of around 16%, but more substantial in the dose expansion group. And then this, I think, is the take-home message for the audience this morning, is that the response rate was a very solid 30% in terms of both the dose escalation group and the dose expansion group. And then if you looked at the triple-class refractory group, which is obviously of prime interest, again, that corresponding response rate is preserved. So about a third of patients responding, and these responses were generally durable with a substantial DOR median seen, and at the same time, in that context, here you can see it's a median DOR of around 7 months. And at the same time, just recognizing this is all oral and just iberdomide plus dexamethasone. And the PFS does reflect this too, although the PFS median is a little more modest, as you could imagine, at around 3 months. So again, as a beginning, this is encouraging. And remember, this is in a heavily pretreated group of patients. And the overall survival, obviously, suggesting that this is a good platform that can then be moved on to with a median overall survival around 11 months. Now, this to me is the most important aspect of iberdomide to share, Neil, is really its excellent tolerability. As Saga likes to say, if you look to the grade 3 and 4 categories here, there are a lot of zeros. And that, I think, is the critical point. You have an oral agent, well tolerated. The biggest issue is hematologic toxicity, which is generally very manageable. But if you look at the non-hematologic toxicities, they're all generally low grade and broadly manageable, as you can see from these data. And importantly, in terms of the adverse events that are serious, Most of these occurred in the context of disease progression. And it's important to note that we enrolled to this study during the height of the COVID pandemic as well. And in that context, we were very pleased to see that our rates of COVID-related mortality were strikingly low. So this was actually quite encouraging. And then the obvious next step is, well, where do we go with combinations? And I just want to share with the audience some preliminary data in that regard. Iberdomide combined with various drugs has shown great promise, both bortezomib-based and carfilzomib and daratumumab-based. And in that context, I'm just really sharing here the IBER-DARA-D cohort of patients, 46% response rate, durable responses in a heavily pretreated population. And then when combined with bortezomib, again, the response rate approaching 60%, which is quite interesting. And I think certainly supportive of the synergy of this approach. And then if you look at iberdomide carfilzomib, actually 50% response rate. And I think one has to be careful comparing across cohorts, but nonetheless, evidence that this combination strategy is a powerful one. So going forward, Neil, with iberdomide, it's been first deployed in early relapse, and then I think its real promise, frankly, lies in newly diagnosed disease, and in particular in maintenance as well, potentially.
CELMoDs have been combined with IMiDs?
No, that has not been pursued. I think the concern there would be overlapping toxicity, and I think the issue there also would be the construct of, this interaction with the Cereblon E3 ligase complex. It would not be clear to me exactly what benefit that would have. Certainly the preclinical modeling combined with proteasome inhibition and separately with monoclonal antibody strategies, including daratumumab, have been very promising. So I think the synergy is clear-cut with standard backbone drugs. And I think the critical takeaway, Neil, is that this is an oral therapy. It's truly off the shelf. The schedule is dosed daily, 3 weeks on, 1 week off. Very easy, very simple, and very important for community providers to have.
I'm curious also in terms of your clinical experience, seeing these patients in terms of non-hematologic side effects compared to, for example, lenalidomide or IMiDs. Do you see a difference? They seem to be better tolerated?
They do. Iberdomide is a remarkably well-tolerated drug in my experience. It's really, there's minimal neuropathy. The thrombotic signal is zip, with the appropriate oral antithrombotic therapy, be it aspirin, or for a higher risk patient, a DOAC or a low molecular weight heparin. There's nothing cardiac. There is nothing in the way of non-hematologic side effects that are striking. It's primarily dominated by myelosuppression, which again is manageable with dose reduction, schedule change, and supportive care.
What about dermatologic problems compared to, say, lenalidomide?
I think it's a great question, Neil. I think in my experience with iberdomide, it's been less, and similarly with mezigdomide, which we're coming to in a moment. I think those somewhat troubling cutaneous and gastrointestinal side effects are substantially less with the CELMoDs. I think it's important to note that with mezigdomide, which we'll talk about in a minute, because of its significantly greater potency, we do see some dysgeusia with it, which you don't necessarily see with the IMiDs. But I think that's a very manageable side effect, actually. It's just a taste change. And generally speaking, you can manage that with appropriate strategies.
All right, please continue.
Lovely. Thank you, Neil. Well, it's really my pleasure to share with you the mezigdomide story now, and just to acknowledge my co-investigators in this space, because today, as it happens, this very afternoon, a New England Journal paper will be published online with an accompanying editorial of our phase 1/2 study. So the data I'm going to share with you actually embraces that experience, but has obviously been presented previously as part of international meetings. But just by way of background, mezigdomide, or as we affectionately like to call it, Mezi, is basically similarly adapted for rapid and maximal degradation of target proteins, in particular Ikaros and ALOS, but its potency is particularly striking. It's not only against the myeloma itself, it's profoundly immunostimulatory, and there's this potent anti-proliferative and tumoricidal effect that we see in not only de novo cell lines, but most importantly in patient-derived tumor cells and len and pom resistant cells. And this, I think, is critical. And when we combine mezigdomide with standard of care approaches, including steroids, proteasome inhibition and monoclonal antibodies against CD38, there's tremendous potency preclinically. And of course, mezigdomide now has been evaluated in a number of clinical trials. Now, I think the important sort of substrate data to share with you from a preclinical standpoint is summarized here. As you can see on the left of the slide, Mezi is a large molecule by comparison to Len and POM, although obviously it still falls into the small molecule class. That difference in molecular structure is critical for its engagement into the E3 ligase pocket and the different effects that it generates. And you can see at the top of these figures the degradation efficiency seen with mezigdomide, or 480 as it is on this slide, and it's quite profound. And the same phenomenon is then seen as it translates to apoptotic induction kinetics, which are summarized on the right, and this in turn translates into potent antiproliferative effects in lenalidomide and pomalidomide resistant cell lines. Now, our first presentation of the phase 1 data in this regard was at ASCO now a couple of years ago, in fact. And as I mentioned, this is part of the New England Journal paper coming out this afternoon. And what you can see here is that we did a complex phase 1 dose escalation strategy with an adaptive design. In the interests of time, and because obviously it's now published in full manuscript form, I'm going to move through this quickly for you. But suffice to say, we explored a variety of schedules, both continuous and intensive, to best understand the best way of administering this drug. As you know, Neil, FDA have been very focused through Project Optimus of trying to optimize dose and schedule, and we embrace that in this design. And what you can see is we then moved to a second phase, which was a cohort 2 dose expansion. But to cut a very long story short, we had continuous schedules that we evaluated and intensive schedules, and basically landed that the recommended phase 2 dose was actually 3 weeks on and 1 week off, and the dose that we landed on was 1 milligram, based upon a comprehensive and complex pharmacokinetic and pharmacodynamic assessment of the dose effects that we saw. So as you can see on this, we escalated from 0.1 up to 1 in a highly organized fashion. We explored with the more intensive schedules slightly different doses, again on a BID versus QD schedule. And so with this sort of comprehensive approach, and especially by looking at the effect on the target on ALOS degradation, we were able to also correlate this with response. And by doing that, really land on a dose and schedule that we felt optimized the best structure of dose and schedule to take forward into further clinical trials. Now, these were the baseline characteristics of the the first part 1 population. And as you can see here, the median age was 66, with our oldest patient being 78. And again, a significant proportion of these patients actually had extramedullary disease. And I want to bring that to your attention, Neil, because that's a group of patients in whom prognosis is especially poor. And as you can see here, 37% of these patients had extramedullary disease. So this was a sick group of patients, a very heavily pretreated. And that's summarized in this next slide, as you can see here, with not only triple-class refractory patients, but you'll see in a minute that we then took the next step and looked at patients with BCMA exposure. In any event, focusing on this first group, you can see here that the majority of withdrawals were related to progressive disease, not to toxicity. In terms of the toxicities that we encountered, these were primarily myelotoxicities. We did see 1 grade 2 pneumonitis, which proved very manageable, and a second 2 patients. But again, with dose and schedule change, we were able to manage these. But apart from those, neutropenia and thrombocytopenia were our major issues, with neutropenia being the major one, and again, manageable with growth factor support and dose and schedule change. And I've summarized them here. And I think prophylactic GCSF in this trial was not permitted in cycle 1 to allow really our ability to understand the impact of dose, and obviously a requirement from the FDA. And then second of all, we were then able to move forward with appropriate supportive care. And one thing I'm particularly struck by in this data is if you look here, no patients discontinued due to adverse events from the actual drug itself, which I think is an important signal as you're doing your dose escalation. Then what we saw here in our pharmacokinetic and pharmacodynamic summary is a complex series of figures, but the takeaway here is by looking at the pharmacodynamic exposure as well as pharmacokinetic effects, we were able to best land at this construct of 3 weeks on and 1 week off, and that this dose exposure mattered. And then this was what was very interesting. In this part one of the study, we saw a response rate of around 55% at the recommended phase 2 dose. Now, small number of patients, so we had to be careful, but we were encouraged by this. And in the overall response group, we saw a response rate of 40%, which we thought was very interesting and good to go forward with. Now, if you look at the characteristics of some of these patients, we clearly also showed a dose response, as you can see here, by virtue of the swimmers plots that we're illustrating here. Now, this is the first case I wanted to share with you. This is actually a patient of my colleagues, Nizar Balis. Nizar is actually the senior investigator on the study and served with me. I've served as the principal investigator, but the two of us obviously were the lead investigators for the trial. And in any event, this is one of Nizar's patients. And as you can see here, what was particularly striking was this extramedullary response for an oral therapy. This patient was heavily pretreated, triple-class refractory with a substantial liver lesion, and as you can see, complete resolution. And when we looked at this extramedullary cohort of patients, we saw a promising signal. This wasn't just a one-and-done phenomenon with Nizar's patient. We saw this more broadly across the cohort. And it's important to recognize that the molecule was actually designed to optimize penetration into tumor mass by virtue of some tricks of medicinal chemistry. And so as a result of that, we were very pleased to see that.
So I don't know if you know this, but I'm just kind of curious, in this patient where you just showed this liver lesion going away, which is really interesting, do you know how the patient tolerated treatment?
Very well. Yes, Nizar and I went over this case in detail. It's his patient, and the patient actually had a complete response. So I think we were very pleased with that result. Because again, you're so right, Neil. We've got fabulous new approaches in myeloma, as you know, with the CAR-Ts and the bispecifics. Powerful and potent as they are, there are logistics behind them that are substantial, and above all, there's some important toxicities. Tolerability with this oral approach is obviously one of its biggest, in my opinion, assets, because it really is a truly off-the-shelf approach.
Do you know how long this man's response was? Is he still responding?
I don't know most recently, but at the time it was a durable response, as Nizar shared with me, as you saw from the swimmers plot. So this was encouraging. And again, recognizing this is a very heavily pretreated population. But I'm going to show you more data that will actually, I think, further strengthen that discussion. So if I may, I'm going to move on now to the dose expansion cohort, which was the sort of part 2 of the trial. And what you can see here is that we took the 1 milligram, 3 weeks on, 1 week off. And I'm going to present to you the data that we presented at ASH in December. And of course, it's obviously been refined and updated for the final paper, but nonetheless, the basic construct is the same. Essentially, here we looked at dexamethasone once a week. This was clearly shown in our original dose escalation phase to matter. All of these patients were steroid refractory, of course, but what we also knew is that there was synergy between mezigdomide and steroid preclinically, and this was important going into the clinic. So here we are with the baseline characteristics. There were over 100 patients in this part 2. The oldest patient, and I'm very proud of this, was 85. The median age was 67. And as you can see here, our extramedullary disease was seen in almost 40% of patients in this cohort. And also, very importantly, high-risk cytogenetics were enriched, 37%. Now, I think the important message for the audience, too, is what were the pretreatment characteristics? Well, what you can see here is all of them were triple-class refractory, which I think is critical, and 30% of them had been exposed and or were refractory to BCMA, including antibody-drug conjugates, as well as bispecifics in 8% of the patients. And of course, we also had a small number of CAR-T recipients as well, in whom CAR-T therapy had failed. So I think it's important to focus on this group because this is also a study that was performed and enrolled during the height of the COVID-19 pandemic. As you can see here, the good news is that in terms of the mortality rate, it was related primarily in the context of disease progression. And importantly, discontinuation was dominated by progressive disease, not toxicity. And in that same context, with dose reduction and dose interruption, we were able to manage side effects, but actually very few patients discontinued due to adverse events with minimal treatment-related mortality. And if one wants to look at this in more detail, you can see here we did see some infections, but the rate was low. And certainly when you compare this to what you see with antibody therapies, be they bispecific or monoclonal in the context of CD38, for example, we were very pleased to see this. essentially the rates of pneumonia were significantly lower overall. And when you look at this mortality slide, you can see we only lost one patient to COVID-19, which I think in itself says a great deal. So what about other treatment adverse events? I'll be very quick here. They're really related to myelotoxicity, and again, the not myelotoxic side effects were manageable. This, I think, is the key slide for the audience. As you can see, the overall response rate mirrored what we saw in the dose escalation part of the study at 41% at the recommended phase 2 dose. When we looked at the patients with extramedullary disease, we were very pleased to see a response rate of 30%. And obviously this was all independently verified. And then excitingly, in those patients who had received prior BCMA therapy and or were refractory to it, we got a 50% response rate. So this was particularly encouraging given that, as I say, this is an oral agent administered combined, with dexamethasone. This just drills down a little bit more in detail. The median duration of response approached 8 months. And then I want to share with you the case, because I think as clinicians on the call today, this is what really, gets us excited. This is one of my patients, very heavily pretreated, triple class refractory, exposed to BCMA. He'd actually, in fact, received belantamab mafodotin. He was too fragile, in fact, in many respects, to benefit from CAR T or bispecifics at this time. So this was an important option for him. As you can see, he was absolutely, he had enormous tumor burden from extramedullary disease. This PET-CT is pre-therapy at the bottom here, as you can see. And literally after 4 months of mezigdomide and dexamethasone, he entered a complete response, and you can see the PET-CT to corroborate that at the top of the slide. So this was a remarkable result. This poor gentleman literally had plasmacytoma growing across his border cath, and then with the treatment effect, this disease responded, and my nurses were telling me we can now access his port to give you a sort of bedside flavor of how remarkable this was. So we were very pleased to see this response, and particularly importantly in this gentleman, his tolerability of treatment was remarkably good as well. Now, what about durability? Well, this is a doublet, and this is an oral doublet in the setting of highly refractory disease. So the median PFS for all comers, 4.4 months. So we clearly need to improve on that. And I think with maturity and time, that will improve. But as a starting point for an oral option, this is exciting. And when you drill down and look at the DOR, if you achieved a very good partial response or better, it improved to 9.2 months. For the group overall, it was 5.1, and in fact, the updated DOR is 7 months. But my point about it is that this is a starting point for next steps. And remember, Neil, this is just a doublet. This is just two, mezigdomide and weekly dex, and we're clearly moving in new directions very quickly to take this further. Now, one piece I did want to share, if I may, Neil, with the audience, which I think is so interesting. This is actually one of my patients. When we took patients off of pomalidomide therapy and moved them straight into 480, one or mezigdomide, there was a real concern that these patients would be primarily refractory. Well, this is a really interesting example of why this is not the case. As you can see on the left here, when my patient was screened for the study, the immunohistochemical stain for ALOS is markedly positive in his tumor cells. Icaros and ALOS are the two degradation proteins that are key targets from the Cereblon E3 ligase complex, and those two targets are how you basically then influence tumoricidal and immunostimulatory effects from this pathway. This pathway is vital to B-cell pathobiology broadly. So in myeloma in particular, these are key targets. So degradation of these proteins results in dramatic direct effects on the tumor cell and also immunostimulatory effects. When that patient subsequently received treatment, just 1 week of therapy, look at what had happened. And this patient literally had just come off isatuximab, pomalidomide, and dexamethasone. And you can see that the change in tumor ALOS is summarized in more broadly for all the patients in the next two figures. And the change in the immunophenotyping is quite striking, with activation of NK cells, T cells, and both CD4 positive and CD8 effector memory cells also being affected. So this was a really striking correlative science to show.
Is there any relationship between the amount of ALS expression and response to treatment?
Great question. We'll be looking at that. But I think our sense is that obviously, because it's obviously ubiquitous, it's something it underlies the pathobiology of myeloma in all myeloma cells. It's probable that the greater the degree of degradation, the greater the effect. the thing is that having too much ALOS is bad for you, and having less of it is better for you. And I think the point here is simply that this patient had clearly become resistant to pomalidomide's effects in this regard, and yet responded robustly to the impact of mezigdomide. So we were very pleased to see that particular patient result. But on the right of the slide, you can see obviously the broader study results from all the patients who contributed samples to allow us to be able to generate this data, which was, I think, I really want to acknowledge my co-investigators and in particular our patients, because this is the kind of data that really helps understand the story. So with that in mind, I just wanted to quickly go to where we're going next with this, if I may, Neil, because obviously Mezi-Dex, it's a great oral platform to see that kind of response rate with durability shown, and above all, excellent tolerability and real-world application. That's a great starting point. Where are we going? Well, obviously, combining this with other drugs is the key. And when you combine this drug, for example, with proteasome inhibition, you can see really nice results, as you can see summarized here. This is an extensive experience now, but I want to just show you this were heavily pretreated, again, enriched for more adverse features. And very importantly, they were highly refractory to their therapies. And again, you're seeing this is combined with bortezomib. You're seeing mezi-bortezomib dex generating for you a 68% response rate, which again, in this highly refractory population is pretty encouraging. And the swimmer's plot shows it's pretty durable. Interestingly, when you then combine this and look at this in a dose expansion cohort, that mezi-Velcade dex or mezi-bortezomib dex combination improves even further to 82%, which was particularly striking to us because, again, this was a heavily pretreated group. Interesting enough, mezigdomide with carfilzomib, the response rate was also very respectable at 62%. And this is really a summary of the safety profile, which is, again, dominated by myelosuppression, but not non-hematologic side effects. So I really wanted to finish up here, if I may, Neil, in the interest of time, to share with you that we think mezigdomide is really a remarkably promising CELMoD with a clearly differentiated preclinical and clinical profile from the immunomodulator class. What's particularly exciting to us is that in triple class refractory disease, there's this very solid response rate of 41%. And if you look at the extramedullary disease, it's 30%. And then what's particularly striking to me is in the BCM exposed and or refractory group, it's 50%. And again, for an oral therapy. And I think with the lack of complexity or resource is needed to generate that kind of response rate generated by an oral approach, I'm really encouraged by these data. I also recognize we need to go obviously do a lot more. I mean, especially in these days, biospecifics are generating response rates of 60 to 70%. So can we get into that territory? Well, it seems that we can, particularly when we combine this with other standard of care backbones. And I think that's particularly exciting. And we've summarized in the trials here that are doing that. Well, I want to speak to you about the newer directions with degraders. And we're participating in this trial actually with led by Jesus Padeja and others, and actually Sagalonio. Basically, this is a degrader. It's so-called CFT7455. And this has some differences to a classic CELMoD in terms of its structure. In fact, I wouldn't say they're the same, but the downstream effect is the same in that they are both in the degrader group. And this actually has been quite selective in its effects preclinically. It's a novel protein degrader. It binds to the Cereblon E3 ligase complex, and of course has this impact on the same transcription factors. But what's important about this is that obviously it has a different molecular structure. It's also orally bioavailable, actually, which is exciting. And I think at the same time, it's a platform which is currently under study. And in fact, in our own participation in this trial, it's actually work preclinically developed by my partner and mentor, Dr. Ken Anderson. But importantly, this is in development and in phase 1 at the moment. So coming along. It is different to the CELMoDs. That's important to share. It's oral. The targets are similar. And we'll see, based on the phase 1 experience and so forth, how it differentiates from the mezigdomide and iberdomide experience to date. And so I just want to finish because I especially want to acknowledge the co-investigators on the study who were really amazing to work with. And the phase 1/2 team were really quite superb, in my opinion. And then, of course, our respective philanthropy support and advocacy from our various patient support groups, and all of those captured in this slide. And thank you so much for your time.